What's up, guys? Welcome back to From the Ground Up. Today's episode is for every clinician who's ever felt stuck with a chronic pelvic pain case and thought, there's got to just be something I am missing here. I am so excited because I'm sitting down with Paige Genova. She is an occupational therapist and she is the founder of Vital Pelvic Health and Wellness, which is a multidisciplinary pelvic floor therapy clinic in Youngstown, Ohio area. She has spent over a decade in healthcare working with complex cases. And for the past 5 years, she's gone absolutely all in on pelvic health. Paige is also the creator of Pelvicology, which I just love this term, and we're going to get into that here shortly. Her signature approach that blends pelvic health, which is the science of the body, neuropsychology to treat complex conditions at the root level, y'all. And this is not just another pain science conversation. This is going to be how to actually apply pain reprocessing therapy in your clinical work. And I'm so excited because, side note, if you are in my clinical mastermind group, Paige is actually also our February expert masterclass speaker. And she's going to be diving even deeper into this exact topic. But today I'm excited because we get to give you kind of the why, the how, and some next steps that you can take into the clinic tomorrow. So let's go. I am so excited to have you here, Paige. Thank you for coming.
Thanks for having me. It's always so much easier, I feel like, to just hash things out verbally. So to get all of these ideas and just get people on board with this. And I like the analogy of the Matrix because I'm a millennial too. Take the red pill. It's time, guys. We got to take the red pill and we got to dive into this.
No, this is what I love about you because I just love a passionate person who is just passionate about their thing and is at all cost doing the thing to drive it forward. And so I want to start there actually, because with all of my guests, I always like to start kind of with your why, because in my life and in my business and in my clinical treatment and in my leadership, I talk so much about the power of starting with why. And so I would love to hear kind of what is your why behind doing things differently in pelvic health and kind of why pain reprocessing therapy.
Yeah. So I've always had a background in neuro and more neuropsychology. When I first got into occupational therapy right off the bat, I was in the ICUs of a level 1 trauma center. And I was all in on it, passionate, loved it, the intensity, the critical thinking on your feet. And I quickly started to realize that a lot of these patients had neuropsychological issues, ICU delirium. And so while I was treating, the body for most of these patients from a very rudimentary, basic, rehab standpoint, the thing that I really started to find myself kind of diving into, which because my undergrad's in psychology, so that kind of is that's the start of it, was my psychology degree. And just really realizing that ICU delirium was huge. The brain is trying to piece together the missing gaps and coming to a incorrect conclusion for these patients. And a lot of it's environmental, sensory, and visual, auditory, just was really, really interesting to me. And I loved that. And so I've always been in that realm. And that was what my foundation was. And so fast forward, 5 years, I get introduced to a pelvic health PT. And I was instantly hooked. I was just what is this? I feel like everyone's origin story is sort of I heard about pelvic health and I was not me. That's weird. And then they later on find themselves there. And I was that wasn't me. Literally the first words she spoke, I was I love it. I'm into it. And so that was a long time ago. That was 7-ish years now. And I got kind of thrusted into it. She was able to help me. And thankfully, she was really one of those new age pelvic health practitioners where she was it's, the whole body. It's not just the Kegels. It's not just strengthening. And so she was the first pelvic pot, that OTPT mind that I was introduced to. And I'm so thankful it was her. And so she was helping me along the way, but then she had to leave and I was left to kind of just treat all the pelvic health patients. And so I really didn't know anything, truthfully. Like I had taken a couple of Herman Wallace courses. She was there to guide me, but she wasn't real like exercise heavy or like really like orthopedic based because she was treating kind of that whole like person. And as an OT in especially in the ICU, where it's like we weren't doing exercises. It was like, are you gonna survive if you sit up on the end of the bed? Are you gonna eat the comb if I give you this comb? Like so it was not exercise orthopedic based at all. So when I got kind of thrown into pelvic health, I didn't have this robust like ortho exercise database in my mind. And so I had to go off of what I knew and what I kind of could formulate with the person sitting in front of me. So it was a lot of kind of neuro psychology, OT, but with like the pelvic health principles. And along the way, I obviously learned a ton of ortho and a lot of exercise based stuff and love treating that too, from that standpoint. But these really complex, chronic, persistent cases that were coming in, I was getting them better quickly, very quickly. And I had no idea why at the time. I was just sort like, I was flabbergasted. They'd come back and be like, I feel so much better. And I mean, I truly was
You're
like,
like,
what
what
the
did I
heck?
do?
Yeah, like that's amazing. And I mean, I would be trying to do some of these, manual orthopedic type things, but like, day 5, I'm getting the most complex patient I've ever seen in my entire career. And I'm doing these manual things and I was not doing anything. I was like, beep, boop, beep, boop. I had no idea what the heck I was doing, but she was getting so much better. And I just started seeing that over and over and over again. And I was learning so much from these patients. And I was like, what is it that is, what is it that is getting them better? And I'd start to hear them say things like, I was in this huge flare up, but today, the day of my appointment, weirdly enough, I feel so much better today. And I'd be like, well, that doesn't make sense from a, physiological standpoint. Why would you have, come out of the flare today or the day before your session with me? So I started to just really evaluate what the heck was going on. And I was finding my footing in sort of this different technique than what I was being taught in a lot of these courses. And I was still absorbing all of that because it's a toolbox, it's like you have to pull out what you need for that patient in front of you. But a lot of my patients were complex and chronic, really persistent cases. And I found myself applying my psychology neuro principles all of the time for these people. And I just kept evolving it. I kept evolving, adding this in, guided imagery. Let's do some graded exposure. I'm hearing a lot of fear. Let's like talk about some of these emotions, like let's just hash it out here. And so many of these patients had anxiety and depression and a ton of fear around these symptoms, medical trauma, medical anxiety, birth traumas. And that just became a really important piece for a lot of these patients. And over the years, I just have kept diving into it, research, different psychological training, like the pain reprocessing therapy, which is kind of now being termed as like neuro reprocessing because it's not just pain, especially in pelvic health. It's, a lot of symptoms. But then I started to realize, especially as I got new therapists, they didn't like, how can I teach this to them? This very unique way that I've been treating these very complex cases. Like, how the heck do I teach it to them? So then it was forcing myself to like get it on paper and create a bit of like a framework for it and something that was teachable for them, things that I knew worked, things that I knew didn't work over the years for these people, and create it in a way that was pelvic health, orthopedic, neuro, which we are all really good at neuro. We just forget about it in pelvic health, and psychology, and being able to wrap it up in a package that didn't feel like woo woo. Not that that's bad. It just,
I know. Yeah.
it didn't land with me and it didn't land with some of my patients and it
Sure.
wasn't going to be landing with my therapist. That's not their vibe. So
Sure.
a lot of this education we're getting as pelvic health practitioners is missing the mark heavily on how we actually treat it. They're talking about it. Everyone's talking about it. Central sensitization, pain, pain neuro education. Everybody's talking about the importance of it, but nobody's teaching anybody how to actually treat it beyond kind of the most basic stuff. So once I realized that that was a huge missing piece, I love teaching and I've been doing it with my therapist for years now. And I was like, well, let's go. Everyone, let's help others help others.
Yes, I love that. That is such a consistent theme in the people that I really consider kind of like leaders in the field of pelvic health in general, but also, people who are great at leading their teams and stuff. It's like a very consistent theme is we found something that we want to make better and teach others how to do it. And that is a strong driver. And I think that's really what helps us kind of stay in the game and make a true difference is it's not just, well, I want to be a better clinician. It's like I am a better clinician and I do want to continue to learn and how can I like make this bigger than just myself? And how can I impact the field so that we impact more patients and people? So I love that because that's such a common theme that I've been hearing in, my guests and just people that I talk to who I consider very strong leaders. And you guys all kind of have this similar underlying theme of it's bigger than just me. It's let's change the game, truthfully. It's like you guys are all like, let's freaking change the game and whatever that looks like to you. So I love that. And I would love to kind of hear from you more of like what exactly is the technique? Are we talking about pain reprocessing therapy? Or you said it's changed to neuro reprocessing therapy? Or are we talking, is your technique like more than that? Or I would just kinda love to hear what is it? What are you doing?
Yes, yeah, for sure. So the kind of the neuroplastic neuro reprocessing therapy is a tool in my overall approach because the traditional pain reprocessing therapy that I've taken, and I'm just finishing the next kind of level of that, the mastery level of that training, because it's synthesizing it all, making it make sense for us as public health practitioners because we are different. It is different for us. Our patients are just dealing with different things than like shoulder pain and or like a migraine or chronic back pain. It's so much more than that, and often there is for those patients, and that the kind of the pain reprocessing hallmark is like the back pain study that they did. And those patients a lot of time have had a very thorough medical markup and cleared of any structural medical issues. Our patients, I feel like, have gotten so mismanaged medically that there is a lot structurally and tissue wise and bodily that gets wrapped up in it that we have to be able to dance with and treat. And so, one of the tools that I use is kind of this neuroplastic reprocessing therapy. But I feel like for us, it needs to be more than that. And then it's how do we add in the musculoskeletal piece? How do we add in the manual piece and do it eloquently and strategically? Because I feel like right now in the world of public health, we're sort of like pain neuroscience education. Adrienne Lowe has been like a massive driving force and just freaking amazing and kind of pioneer for us, I feel like, in pelvic health. But that isn't the whole picture. And, we are evolving. I feel like that really paved the way, the pain neuroscience education. But that, if we just rely on that, we are missing a massive, massive, massive long-term actual relief. And so the process that I've kind of created, it's a 6-step process. And step one is the pain neuroscience education. And educating the patients. But I feel like as a whole, we're kind of like, I educated them and did some vagus nerve stuff and like checkbox. Now I can back to do the manual stuff that I love to do and is my wheelhouse. Thank goodness that is over with. And it's like, I totally get it. And that's kind of where I was in the beginning too, was just like, if I just educate them and help them understand it, then that's going to be all I need to do. But that for some patients, and that's kind of in my like third step is like finding what percentage they are. Is this somebody where it's like 90% neuroplasticity, or is it like, a little bit of neuroplastic symptoms, a little bit of that mind body piece, maybe like 20%, but the rest is really manual musculoskeletal, but it's a part of it. So for those people that have a small piece that is neuroplastic, this is early on in their symptoms. There aren't a lot of kind of comorbidities. They don't have, medical trauma and a bunch of fear yet. That education piece might be enough. It might be enough, to get them reoriented and get them on the way that they need to go. And then you can finish off, have the plan of care with the manual musculoskeletal stuff. But for a lot of our patients, because we know that a lot of our patients have really complex. They have central sensitization. There is anxiety, there's depression, there's preoccupation, there's hypervigilance, all this other stuff that pain neuroscience education isn't going to cut it. Short term, it will give them a bit of like a placebo effect, and that will help them. But we have to actually rewire the pain neural pathways that have been made that are incorrect, that are just not correct communication. So that's really where then we go through the rest of it, where it's like we're educating first, but then we are figuring out, what percentage is this person? Because everybody's going to be a little bit different. And who better than us as people who have license to put our hands on people and also treat the brain aspects of it. Like, who better than us to figure that percentage out for them, Like, why are we going to be, relying on somebody else, if we are always referring out any chance we get to a mental health practitioner, which can be needed. They can't treat the body, and so they can't put their hands on these people. So like, let us figure that percentage out. What is the driver of this and what part is body? Because there's always going to be both. So it's really like marrying the two of them together in a strategic step-by-step way. You're starting here, then we're adding in, the manual therapy, all the exercises, but in a bit of a different lens for these patients. Then we're starting to get these real psychological corrective experiences for them that start teaching the brain something new, just like a stroke patient. Like that's why I'm always like, guys, this is us. Like, this isn't weird. This isn't like something outside of our scope. Like, we are trained in neuroplasticity. This is all it is. It's just in a different way. And giving people guidance, because a lot of our profession stops at the education piece and the like polyvagal theory type stuff, which is a piece of it, again, a piece. But we are stopping there, and we are doing our patients and ourselves a huge disservice because we are extremely skilled. We are the best person for this.
Wow. Oh my gosh, my brain's exploding. I have so many thoughts. This is so helpful and so good. So what I'm kind of hearing is your kind of methodology, your framework that you've been able to take from your brain and kind of put on paper, if you will, is more of like a way to work through and synthesize what we're seeing in front of us from our patient, kind of how to prioritize, where to start, what types of interventions to use, how to pull from our toolbox, both from like the neuro stuff, the psych stuff, the behavioral stuff, the manual, the exercise, all of that. And it kind of gives us a map almost of what the heck to do and when. That way we're not stuck in just being like, oh, it's a chronic pain person. I need to, only do breathing exercises or whatever the case may be. Gosh, yes. This is so necessary, so needed, so this is missing. Like, as I'm hearing, like, I even thought I already knew what you were going to come talk about today. And I'm over here like being mind blown myself of just like, I knew we needed this, but we need this so much more than I thought. And so like, this is massive, Paige. Like, this is so massive. What would you say? Like, how can we start as clinicians? What the heck do we do? Like, what is the steps that we need to take to be able to learn this stuff and actually apply it?
Yeah. So, I think the first step is opening up our minds a little bit and unlearning some of the stuff that we've learned, because the harsh truth is that a lot of the manual stuff that we have been taught over the years is not effective for chronic symptoms. And, the research is showing it. And it's not that it's bad. It's not that it can't be effective, but really starting to open our minds to a bit of a different approach. Because if we think about it, we are outpacing like the need as PTs and OTs in a lot of ways, right? Like, there are so many of us. Our professions are exploding. We are becoming so skilled. We have such great techniques. We have exercises at our fingertips. We have everything that we need, right? Except chronic pain is outpacing all the other chronic illnesses combined. And it's growing and it's growing and it's growing. It's like it's crazy statistic, like diabetes, heart disease, and something else, cancer, I think, combined. There are more chronic pain cases than the top other, ones below it combined. So what is it we're doing wrong? Like, and really looking at it and being like, we're not treating chronic symptoms properly. As a whole, we are a part of that. And not being kind of stuck in our ways of being like, well, I've always been able to, help people with my orthopedic approaches. But starting to really like look at our biases, like when that patient walks in the door, are you kind of dreading it? Are you kind of like, oh my gosh, like this person, they're flared up after I gave them these exercises and I have no idea why. And they are so anxious and they're just spiraling every session and they can't do their exercises. They're overwhelmed. I'm trying to tell them to sleep more and get them on this diet, but that seems to overwhelm them more. And I'm just done. I just want to be able to freaking go see then my orthopedic person, and like being okay with that and being like, all right, well, what can make it easier for me? What as a practitioner, how can I better show up for this person and make it easier for me to be able to help them? And it's very uncomfortable to realize that it is our duty as their pelvic health practitioners and that the vast majority of our patients have neuroplasticity wrapped into their symptoms, that we have to treat it. We have to treat it. But then it's like, how do we treat that, And I feel like that's the first place, is being able to wrap your head around it. And then we're going to look at the research, let's look at some of these hallmark studies that prove that expectations, cultural, personal expectations will literally give you the symptoms. Like your brain can produce whatever it wants, whether it's anticipated pain, perceived pain, whether it's actual pain, acute injury. It's all in the same place in the brain. They've done MRI studies. It's all through the brain. And they looked at cultural expectations of whiplash in more like Western civilization. I think it was Canada and places. And the other one was Greece, somewhere in the Europe region, where whiplash is not a diagnosis. Like there are some countries where whiplash is not real. Like, America, we get into a tiny little fender bender, we instantly start thinking about whiplash, right? And we expect to treat it as practitioners, right? This happened, this is probably what's going on, these muscles, these bones. In these countries where whiplash is not a known thing, they don't expect it to, like if you get into a car accident, they expect some pain, maybe you got like a headache, maybe some neck pain, but like that's it. When you ask them if it's something that could last months or years, they're like, no, like, of course not. No. But in Canada, they're like, it could be the rest of my life. And then they did one where they simulated with like a little sled. Think of like a bumper car, like kids bumper car type situation, or like a roller coaster, like starting type movement. But then they used special effects and CGI to like make the practitioner think that they got into a car accident. And they just told them that it was going to be I think they just said car accident. And that's what they're anticipating. So they got into this car accident, even though it was way below the threshold. It was like a roller coaster starting, right? Doesn't affect most people, right? And right off the bat, 40% of them had severe symptoms. They had headache, fatigue, nausea, neck pain, and nothing happened. Just the expectation of getting into this car accident created whiplash symptoms. And so what I really wish they would have done was then study those 40% and see if they scored high on like the central sensitization index, because that would perfectly explain why almost half the people had symptoms when nothing happened. They just expected to be in pain. So when you start looking into some of this research and you start looking into, the back pain study, and you start looking into placebo effect too, a whole another rabbit hole. It's like, why is placebo effect so darn good, right? Like why is it that placebo effect is usually short-term just as effective as the control? It's because they have less fear. They're like, all right, I got the pill, I'm good now. I am safe, right? So you would get that initial placebo effect, which is just the brain being in less fear because you've got something to fix it. But it never lasts long term because the rewiring didn't happen. Day one where it's like, give them that reassurance. You're at the right place. I know how to help you. I understand this. It doesn't have to be scary. This is what we know. Taking away that fear of the unknown. All of that is unbelievably impactful and will make them feel better right off the get-go. But it doesn't long-term, will not meet them better, because then as soon as a trigger comes, as soon as they enter back into an activity they previously avoided, that pain neural pathway, that symptom neural pathway that had already been created and been going for years, the brain will recognize these circumstances and it will pull them right back into that loop. And so without the rewiring piece, those patients will always kind of come back and flare up. I think we want to, as practitioners, make pain complex and, talk about inflammation and sleep and diet and all of this stuff, which truly just overwhelms the people in the beginning anyhow and makes their symptoms worse. We can add that in eventually, right? That's something that's good and healthy for them. But we want to make it so complicated. And it's actually extremely simple. But people and our emotions are what's complicated, not the actual symptom. And so when we look at that, where it's like, all right, if they have, bladder pain, I see. The pain itself is actually not that complex if we really look at what's going on. But that person in front of us is a complex being with emotions and history and beliefs and experiences. And that's really for a lot of these patients that we've kind of looked at and decide they have a, high neuroplastic component to their symptoms. That piece is the complex part that we have to work through. But the symptom and the pain piece can be pretty simple. It's sensation plus a fear emotion, and that can be anxiety, frustration, annoyance, fear, whatever. So sensation plus that emotional piece equals pain. So our job is to take that sensation, add a neutral emotional response that's not dangerous, and there won't be pain.
Oh my word. It's literally a simple math formula. Do you have a patient in mind that you could walk us through kind of like her case or his case where this technique, these things you're talking about, like what did it look like from, just kind of throughout that transformation?
Yeah. So there's one patient that really has taught me a lot. She's kind of my hallmark in my brain because she had a bladder infection that was very severe and a lot of complications afterwards. And so it was a very traumatic experience for her. She has medical anxiety already, this bladder infection that got worse. She had to have a catheter put in. She had to, go on all these meds, created a lot of symptoms then afterwards, after the infection has cleared, right? Because her body is very good at healing itself. But after it heals, things that remain, what's going on. So I treated her for all of the things, in the beginning. We looked at the pelvic floor tone. We looked at the connective tissue fascia in the abdomen. We looked at bladder mobility. We looked at vulvovaginal tissue, urethral stuff. We got into like lengthening and hips and all the things that we would do to treat like a bladder pain, bladder urgency type patient. Got her all better. She was doing great, right? And then about a year later, she comes back with significant bowel issues. And hers was mostly incomplete bowel emptying and lots of wiping and a lot of pain with bowel movements. And so we start with the traditional stuff. We're looking at pelvic floor tone, the, puborectalis, pubococcygeus. We're looking at stool consistency and bowel habits and all these things mixed together. And she would get kind of better and then kind of worse. And it'd be like this back and forth of just like flaring up. And you could see that it was so anxiety provoking having a bowel movement for her because she couldn't leave her house because she would just felt like she was like had stool coming out all day long. I could tell that her anxiety and her fears and her mental health was a huge factor in her symptoms and was holding her back significantly. But, like, what do I do? And so initially I wanted to just kind of refer out because it was almost OCD and like symptoms and anxiety. She was so incredibly fearful of going to any other practitioner. She wouldn't. She was like, I'm not doing it. I will not. I will not. And I was like, well, okay, I guess it's on me. All right, let's do this. Let's dig into it, right? And so we really started with talking through like the moment she starts to have an urge to have a bowel movement, what does she feel? Like, and it was instant panic, instant fear of like the unknown, like what's going to happen? How bad is it going to be? Am I going to be able to get the stool out? Is it going to be leaking throughout the day? And once I realized that that was a huge fear for her, I was like, okay, well, let's start there. Because if we look back to that equation, sensation plus fear equals pain. And I was like, well, let's at least get the fear out. And it was a lot of education and just, talking her through that, like, if she is deathly afraid, her brain thinks she's deathly afraid, there's something really bad in that bathroom, because that's the emotional state she's in when she gets that urge, then those muscles are not going to relax. Her brain thinks there is like a snake in that toilet. It doesn't understand that there is like, why she has so much fear. It just thinks there's something dangerous in the bathroom. I was like, when you go into the bathroom and we were working on your muscles and relaxing the pelvic floor and all this stuff, I realized none of that mattered. If she goes into the bathroom, sits on that toilet, feels the stool start coming out, and she panics. Instant fear and instant muscle spasming. And that was honestly the first case of this condition that I feel like I was like, I'm trying to write like a paper on it of getting a new syndrome called rectismus. I am so passionate about this. It is the same mechanisms of vaginismus, except rectally, when they're afraid of when the sensation of stool coming out causes panic and fear because they're anticipating the pain. They won't spasm in a protective way, and then they can't get the stool out, or it's extremely excruciating to empty the stool. It's the same mechanism, right? That was my first time where I was sort of like, this isn't just like her muscles are okay. Her muscles are fine. And like accepting that and being like, I'm done with the muscles because like your coordination, your tone is fine. I need to stop with your muscles because they're okay. So what else could be happening? And so we started going through like how to calm the nervous system down and how to teach your brain something new, that there is no danger in the bathroom. And we did that through, at first, guided imagery and a bit of graded exposure, like having her in my office go through as soon as she feels the bowel movement. What happens? What thoughts is she thinking? I had to write them all down, and they were all so excruciatingly painful thoughts. And if you ask our patients, if we start asking them about their emotions, it's going to be the same thing for all of our patients. Fear of the unknown. How bad is it going to be? How is this going to prevent me from going to work? And is it going to, affect, am I going to have to lay down for the rest of the day? Am I going to have to find a bathroom? Can I even go to that event tonight? Though, it's like a record that just goes in their brain for every single patient. So I had to write those down, and I was like, oh my gosh, she is terrified. She's terrified of this whole act of having a bowel movement. And getting her to realize that why would her brain let her muscles react, especially the pelvic floor, which is a protective, very, instinctual, involuntary muscle group. It's going to spasm. And so when she realized that like the way she's thinking about having a bowel movement is creating her muscles to spasm, and there's nothing that we can do to get those muscles to relax in that moment, except for her own volitional input that she's giving her brain. And so from there, we were able to really, really make a big impact. And that's when then we add in some, we started with the guided imagery, doing it in the safety of my office. You're not having a bowel movement, but just seeing her viscerally feeling what those emotions and the muscle tension and her everything tightening up when she wasn't having a bowel movement was really groundbreaking for her, because she was like, oh my gosh, like, it is, this fear and this feeling is coming from my brain, not actually having a bowel movement. And so once we were able to kind of like then add in some of the polyvagal stuff, I needed to calm her nervous system in a moment, right? We needed to downregulate in that moment. That's when the, vagus nerve stuff is effective, is in a sort of a controlled setting where you're applying it for a moment or for a, short period of time. So she could start to have a bowel movement. So the bowel movements itself started getting a lot better, a lot less pain. She had a lot less fear. Her stool was improving. She was having regular side bowel movements. But then there was this whole new broadened fear of the continual wiping and getting clean. And she was like, I'm still wiping a ton. I'm still wiping a ton. And, we assume our patients know what wiping a ton means and what, what smearing is. And so I'm just like, man, what am I missing? Is there a rectocele? Is there something that I'm missing where it's like she's not emptying her stool? And I could tell that it was causing almost like OCD-like patterns. And so I literally, no joke, I was like, I'm going to take a picture of every time I wipe throughout the day. And I'm going to show you what I have on the toilet paper, like throughout the day. And I want you to tell me if this is similar to you or if you have a lot more. And guess what I found out? that her wiping throughout the day had maybe like a half of a centimeter of a little bit of a yellow tint to it. But to her, that was like, that could be just going everywhere, right? And that she could feel it throughout the day. It was enough to cause her really significant kind of like hyperfixation on every sensation then she was feeling on her rectum throughout the day. Throbbing when she'd be standing for long periods of time. She could feel the leaking, feel stool coming out, but it wasn't. It was just the hyperfixation to the sensations around her rectum. So once we got into that, I was like, what is so scary about it's what if stool does leak out a little bit throughout the day? What if you have a little bit of smearing on your underwear? Like, what's so scary about that? And she was like, well, I don't want it migrating up and causing another bladder infection. And I was like, there it is. That excruciating, terrible fear of having another bladder infection caused this whole bowel dysfunction, right? And so it is really important for us to start noticing those emotions that our patients are talking about, identifying them and talking with them. And again, it doesn't have to be woo woo. It is neuroscience. It is literal neuroscience, right? And our emotion, every sensation we feel has an emotion attached to it. And if our patients are feeling normal bodily sensations, just regular movement at her rectum throughout the day, regular friction of her underwear on her rectum throughout the day, regular blood flow to that tissue, regular tension in the rectum, in the sphincter that's supposed to be there, right? But to a brain that is sensitized and has a lot of fear thoughts around the rectum, it misinterprets that tension and that has to be there as pain. It misinterprets that rubbing as leaking because it's the decider, right? So it is, I think, just so much like once you see it, you can't unsee it for this patient population. And if we really want to get them better, who better than to start asking her about who better than take pictures of my freaking toilet paper
I love
than
that
me?
story.
So it's like incredibly important for
Wow.
us to identify those people. And once we identify them, see what really is the driver for this. Be okay with abandoning some of the manual stuff and the exercises to explore something different for this very unique patient population and getting a bit of a different framework for ourselves. But for her, it was sort of then kind of exactly how I went through it was identifying education. We did manual stuff to kind of like help her to understand what sensations are what at that part of her body. A sensitized brain just feels like it's all bad, right? So like, what does a normal pressure feel like? What does a, normal kind of movement of the pelvis feel like? So doing manual work, but doing it in a way where it's not like, this is a problem and I have to fix it. And then you're applying those neuroplastic techniques. You're getting them to start doing activities that they previously avoided out of fear. And then you're just like on repeat, getting a corrective experience to teach your brain something new. And then you're kind of getting into that more long-term part of it. But it really can be a step by step by step by step process. I've gotten to this point because I've been doing it for years and trial and error. There are some people where like I missed the mark, where I, started talking about this stuff and they just wanted me to like give them some exercises and they wanted me to do some manual stuff. And they were really worried about the bodily part and the tension. And I was like, well, it's mostly neuroplasticity, but like not meeting them where they're at and missing the mark with them. So it's like every patient's different, but like I've trialed a lot of different things over the years to see what universally can work step by step for each patient. And how do we get them to that goal where then in 2 years they go through a divorce or they get fired from their job. And we know that our patients' symptoms will flare during that, right? And for a patient who doesn't have that neuroplastic foundation, they'll flare and then they'll have to come back to you. But if we give these people that foundation of understanding that their brain and their body are communicating, understand what their old neural pathways were, that they have new neural pathways, they're able to identify that this flare up or these sensations might just be because they're feeling more right now because their nervous system is upregulated. That these sensations are normal, their brain's just misinterpreting it as something dangerous. And, helping them to understand that our brain does that all the time. Why does a hot tub feel good? It's burning, scalding our skin. Like why is that,
So
right?
true.
Like if I put my 5-year-old
Yeah.
into a hot tub, without any context, she'd scream and think I was boiling her alive, right? Burning her skin. But yet, after corrective experience, pairing the sensation with like, all right, everyone else says this feels good. So like, this feels good. This feels good, right? Yeah, my brain, like, take this sensation, but I'm going to pair it with pleasure and optimism. And this feels good. And this is therapeutic and relaxing. And now that burning sensation doesn't hurt. It actually feels good, right? Not because the temperature is not arguably really way too freaking hot for our skin, but just because we've taught our brain that that sensation isn't dangerous based off of the input we've given it. So I mean, it's just like when I say it's a rabbit hole that
No,
we
I am here for the rabbit holes. I love them. And I just like literally my brain is still exploding. I think this is going to help so many, just this one episode is going to help so many people. I think, like you were saying, like at least step one is make us aware of that this is true. Like this is
it's
neuroscience.
research. Yeah, it's neuro.
This is true stuff. This is not woo woo. Not that woo woo stuff is bad, but like this is rooted in neuroscience that we have been taught we are equipped to treat with. And like I think even just that kind of mind blowing like realization is going to help so many people who listen to this episode realize like, oh my gosh, like I can do something different and better and kind of go down this rabbit hole and everything. And then like I think the coolest part of all this for me was that math formula. Cause when I'm talking about pressure management, I talk about the math formula that pressure equals force over area and how it's just math and it's just a formula. And so like same, it's just like if we decrease sensation or decrease the negative emotion or change the negative thought about it, like the pain on the other side of the equation is going to change. And similarly, if we increase the negative emotion, like the it's going to increase. And so I'm like, it just makes so much sense.
And I think we know this. Like if we picked 100 people off the side of the road and you did a pelvic floor assessment on them, how many of those people would you be able to find objective tension in their pelvic floor muscles? Maybe we don't put all of our eggs in one basket, ask a few more questions, identify, if this patient has these components of neuroplasticity. If we don't know that that person sitting in front of us has a component of neuroplasticity to their symptoms, we won't know to then add it into our treatments. So I think that's a good place for everybody to be. And, obviously then like know how to treat it, because I do think that's where we're at as a profession is like, I can tell that there is central sensitization and I can give them diaphragmatic breathing and I understand to, downregulate their nervous system, but like, it's not going to get us to where we need to go. And that's okay though, that we're at that next step. It's like we're identifying and we understand the big component to our pelvic health patients. And now the next step is like, how do we actually treat it from a neuropsychological standpoint?
I love that. Is that the course that you're developing? Is that what that's going to be for? Is to show us what to do?
Yeah, the 6 steps, like exactly what to do, step by step by step by step, where to add in the body, how to identify it. But first we gotta go down that rabbit hole where I'm like, take a pill. We're gonna go into the research. We're gonna, I'm gonna blow your mind. What's actually what the research says about how powerful our thoughts and our emotions and our input are for our bodily sensations. But I want them to feel confident, ready, and equipped to help this subset of people, because it's not every patient,
Sure.
right?
Yeah.
It's not every patient, but it's like we all know that person. We can think back into our brains of like
I
that
have one
patient we
right now.
treated, and we're like, man, like that person, and you start to get frustrated, and you start to get, frustrated with them, and you're like, this doesn't make sense. Like that dry needling did not flare you up, right? But it's like we get so frustrated with them and ourselves, and we just want it to be done, and we're like, I'm not the right person for them, but it's like, no, we are.
Gosh, this is so life-changing. Like for me as a clinician, for my patients, like I have 2 patients in my brain that I'm like, I gotta call you and I gotta ask you some questions. And like literally, this is so, so, so good. So I definitely want to link your guide and your chart, and you have a wait list for your course, right?
Yeah. I have it all pretty much ready, but with the holidays, I do have my clinic that I have to run and, I'm thinking more into the new year, but I want to get an idea of like, get people interested, get people on the wait list so that way they can have first access. They can, get some primer information. So you still have time to get on the wait list, but it'll probably be in the new year that I'm rolling it all out.
That's so great. Yeah, we're going to link literally everything because I guarantee you, Paige, everyone listening is on the edge of their seats and everyone is like, I need this. I need this information. So we'll have it all. We'll link your Instagram and everything. But holy moly, like I hope everyone's brain is just buzzing in the best way like mine is because this was gold. This was gold. So huge thank you, Paige, for sharing your wisdom, giving us a peek kind of into the world of pelvicology with Paige, if you will. Like I said, I'll link everything, but I always like to end episodes with my guests with a little like rapid fire this or that just for some fun. So there's no right or wrong answer. Don't panic. But you got to pick one. So just, to round us out, I'll go through my list here and then we can wrap it up. So, okay. Amish market or grocery store?
Well, I live in the middle of Amish country and I could probably see one going down my driveway or down the road here. So I'm 1000% picking Amish.
I love it. I just had to put that in there because I wanted everyone to know that cool fact about you.
Oh my God, yeah. I love the Amish.
Yeah, one of my favorite things to know about you and why I still need to come visit you. Okay, strength training or stretching?
I would say, I'm probably going to say strength training in this realm because most of these patients have a fear of that type of exercise. And the best way to teach their brain that they're safe is to get them to start doing some of those activities that they previously avoided and feared. And most of them know that stretching feels good and they like it. So I'm going to say strength training because that we have to get to that step in a way for those patients.
Yeah, I love it. I'm here for it. Okay, chickens or garden?
Oh my gosh, I have to pick one? Oh, never had anything harder. So I'm going to have to say garden just because I come from a long line of Sicilian farmers and gardener. And so like if I picked chickens over the garden, my ancestors would come to haunt me. So I'm going to say garden.
That's fair. That's fair. Okay, manual therapy or exercise?
I'm going to say exercise because I want the patient to be able to take me out of the need. Like I'm not fixing them. They are their own. They can do this on their own. They don't have to have me put my hands on them and fix them. So I would say exercise because it gives them a little bit more of that independence and control.
Yeah. Yeah. I love it. I love it. Okay. Last one, nervous system or musculoskeletal system?
I'm gonna have to say nervous system because it drives the rest.
It drives everything. Yeah.
Without a brain, we would feel no pain, right? So it's like we have to. That nervous system drives it. So
it does. I love it. Well, thank you so much again, Paige. Everything's going to be linked. Be sure to follow her so you can stay up to date with everything she has coming out for us clinicians. She is truly one of the people that I admire so much. You are out there truly changing the game, Paige, and that's like why I wanted you on the show. So everyone could get a little taste of, one of the best leaders in pelvic health, in my opinion. So, and like I said, she is going to be our expert in my February masterclass of the Clinical Mastermind, and doors are open. So be sure that if you're not in it, join it because this is going to be epic. I mean, you've already gotten a taste and then, we're going to have her for a full hour yet again, and it's going to be so great. So be sure you join that. And then as always, DM me, share the show. That's how we grow, right? That's how we are being better together and changing the game is we're sharing the episode, sharing the show with other clinicians. If you enjoyed this episode, they will enjoy this episode. So share, tag us in it. And I hope everyone has a great rest of your day and let's change the game, y'all.